Good afternoon, everyone, and thank you for joining us for this joint webinar we're hosting today with Barnardo's. I'm Kadra Abdinasir. I'm our Associate Director for Policy here at Centre for Mental Health. We're really delighted today to be able to share some insights from an evaluation we did of Barnardo's Inner Resilience and Development, or BIRD, service. This is a really innovative approach that better supports young people who arrive at emergency departments in distress, but who don't quite qualify for CAMS support. So through our work with children and young people at the centre, we know that there's been a long-standing gap in the system, one where too many young people have fallen under the radar of services. And we're really pleased that through this evaluation, we've seen that the BIRD service demonstrates the real value of non-clinical support in helping to bridge that gap, providing early, compassionate support to young people and their parents and carers when they need it the most. And today you'll get to hear directly from our speakers about this brilliant service, the difference it's making to young people's well-being and what we can learn from its success. So I'm really pleased to introduce to you all our wonderful lineup of speakers today. We've got Beth, Donna, and Emily here from Barnardo's, who are going to talk to us about the BIRD service. We are also honoured to have Lisa, who is a parent who has navigated this service as well, and she'll also be sharing some reflections from her daughter. And lastly, and certainly not least, my wonderful colleague, Dr. David Woodhead. He's going to share some of the insights through today, jam-packed agenda. But before we do, I just wanted to cover some digital housekeeping. I know that we're all used to it since the pandemic, but just to remind you, we are going to be recording this session. The recording and the clips and the presentation will be circulated afterwards, and we'll be using some of it to promote on our social media channels. If you don't want to be captured on camera as well, please feel free to keep your camera off. The Q&A function that's open, so we'll really encourage you to share any questions that you have throughout the presentations, and we'll try and get through as many of them as possible. And yeah, any other sort of resources and links to the report will also be shared in hopefully a digital goodie bag that will circulate to you all after today. But without further ado, shall we just crack on and hear from the wonderful Beth, Donna, and Emily to set the scene for us a little bit. Over to yourselves.
Thank you, Kadra. I'm just going to pull up my slides. Just give me a yes, Kadra, if you don't mind, that you can see those.
Yep, that's coming up perfectly. Thanks.
Perfect. Thank you. So just to build slightly on that wonderful introduction from Kadra, my name is Beth Chard. I'm the Programme Manager in Mental Health, sitting on the National Health Quality and Inclusion team here at Barnardo's, and I've had the privilege of overseeing the BIRD service, not at the delivery level, but a more strategic level since joining Barnardo's at the start of this year. I come with several years' experience in Prince 2 programme management, working in the NHS and also in the mental health space. And I'm joined today by Emily Phelps, who's our Assistant Director of Children's Services in the Central Region, with over 20 years' experience at Barnardo's and previous CAMS nursing experience. And Donna Ryan, who's our Strategic Lead for Mental Health, also sitting on the Health Quality and Inclusion team here at Barnardo's, covering all 4 nations with over 30 years' experience in the NHS as a nurse consultant in psychiatry CAMS, and has also been both an operational and strategic lead in the NHS. So that's just to cover the Barnardo's side that's joining us here today. And Kadra touched on this at the start, but the name of the BIRD service that we're here to talk about today was decided by children and young people through our Voice and Influence team here at Barnardo's. So it stands for Barnardo's Inner Resilience and Development Service, and I'm sure you'll agree, BIRD is far catchier. So just a bit of a background, we were awarded £1 million of funding following the sale of this Banksy painting here called The Game Changer. Many of you will recognise it. And that was in the foyer at the Southampton Foundation Trust. And the aim of this funding was to provide targeted, holistic mental health support across 2 different regions. Now, the 2 regions that were chosen were St Helens in the northwest of England and the Black Country in central England, due to the existing relationships that we had in both of these areas, and where we knew mobilisation, because it had to happen quite quickly, that the groundwork was already in place. Much of this will be touched on throughout this webinar, no doubt, but just as a bit of an overview, the BIRD service is there really for children and young people who present at emergency departments And as Kadra said before, they are not meeting that point of crisis, but they themselves need support for their mental health and well-being, and we know they're better supported in the community. So the approach has been to embed the service into those existing systems, particularly, as I say, where we already had that presence in those relationships locally. And we're really proud of the non-clinical approach and the range of expertise and background that our mental health support workers have within the Bird service. It's meant that it's a really enriching service for the children and young people, and we found it's an excellent melting pot of support for them. This is seen in the report as well, but it means that the service is incredibly complementary to the existing support that's already available in the two areas, and it's really addressing the needs and improving the outcome for children and young people. So in terms of the delivery model, this breaks down what I've already touched on really, but it's that one-to-one, non-clinical, trauma-informed support that's out in the community. It's meeting the children and young people in places that work for them to help them to build their resilience, their emotional literacy, and to support the system around the child or the young person as well, ultimately helping them to feel safer. And I'll hand over to Emily.
Thanks, Beth. So just following on from Beth's slides, who the service is for. The service is for all children and young people between the ages of 5 and 18 and up to 25 for SEND that are needing help or support for their mental health and well-being. And that's sort of quite professional terminology, but the cohort of children and young people we're thinking about is those that are presenting at emergency departments, because in general terms, parents, families, carers are unsure how to access support. It may be that they feel that they're in some sort of crisis, or that they don't know how to manage behaviour, emotions, what the child or young person is expressing. And so it's really sort of trying to capture. We did some early work with Wolverhampton New Cross Hospital that enabled us to think about the children, young people and families we really wanted to support. And from around 100 presentations that were seen in a month that presented under the banner of mental health and well-being, there was estimated about a third of those that were discharged with no further care or support or follow-up. So they weren't eligible for the more traditional CAMHS crisis routes, they weren't admitted to paediatric inpatient or followed up under any other paediatric support. So those were really the children and young people that we were thinking about. And once they are referred into service, this can be done in a number of ways. So we put QR codes on posters and leaflets in the 4 acute trusts across the Black Country and in our colleagues up in St Helens. And so that was a mechanism that families that were sitting in waiting rooms could access that support through a QR code or take a leaflet home and follow up and make that direct self-referral into the service. We also had referrals from the acute setting themselves, so paediatricians, clinical leads, paediatric nurses, ED workforce were able to refer into the service via email or again through the QR code. And we also have built a really robust relationship with the CAMHS crisis teams, because this really isn't around duplicating any services that are already in existence. It's really around supporting what people have got in place. So where there was a process for a CAMHS crisis team intervention, they would do that assessment and that piece of work and then potentially refer on to the Bird service after that, where it was felt that the appropriate support pathway was for Bird rather than CAMHS crisis intervention team. Colleagues up in St Helens had already got established relationships through CAMHS helplines and through the CAMHS community teams. So again, a single point of access was used when it was felt appropriate for Bird to pick up referrals. And the important point to note really in terms of referral pathways is that they're very bespoke to the system that they're working within. So depending on what other services are around, for example, in Russell's Hall Hospital in Dudley, we worked really closely with the safeguarding team who did pick up a lot of referrals around mental health and emotional well-being, and we established how Bird could support safeguarding colleagues where there wasn't a strictly safeguarding need, but there was more around behavioural, emotional, mental health and well-being needs. It's important to note as well that we could also pick up referrals from the paediatric ward, so it may be that there was an admission required, and then we'd be working with paediatric colleagues in terms of some of that discharge strategy. Thanks, Beth. So just in terms of who delivers the service, it's really a sort of team approach, and we've got various sort of different disciplines and different professionals that are involved in delivering bird. So obviously there's good governance and service management in play, and administration support. We record the service on IAPTUS, which I hope that most of you are familiar with. So we are able to capture all the recording and filter into data sets as required. We've got senior support workers who help in terms of oversight, case allocation, referral pathways, some of that partnership work. And we also have obviously the mental health support workers. It's important to say that there's a range of disciplines and backgrounds in our team. So we've got everything from youth workers, people that have worked in social care, substance misuse workers, some nursing backgrounds, some family support backgrounds. But it's really a non-clinical role. It's really around that therapeutic mental health and wellbeing support. And all of our practitioners and our team in the service have clinical oversight, so they have clinical supervision as well as case supervision. So the overarching aims of the service, which have already sort of been touched on, it's really about supporting children, young people and families so they do not feel the need to represent at emergency departments. And hopefully that will be showing through some of the evaluation later on about reduced attendances at emergency departments, but really thinking about those children, young people who present at emergency departments because they were unsure of how else to access support. It's around providing additional capacity and support to the local CAMHS crisis teams and the core CAMHS and the wider sort of services around children's mental health and emotional wellbeing, and reduce pressures on the systems that we know are so evident at the moment. And also, most importantly, to improve outcomes for children, young people and their families that are experiencing acute mental health and wellbeing difficulties. So it's really about building capacity in families, building capacities in the individuals, building capacities in the communities, so that we can really improve outcomes for children, young people. Thanks.
Thanks, Emily. Thanks, Beth. So at Barnardo's, we have really robust policies and procedures in place around clinical quality and governance. And you'll see on this slide what structures and reporting mechanisms are in place that surround this offer. And you'll see the oversight from the trustee to operational level. And a quick couple of examples. So we have a clinical reference group. So that brings together quite a lot of senior clinical expertise in mental health and public health, and that ensures kind of safe, high quality services for our children and young people. And its main function is to support NHS contract standard compliance and kind of inform that service delivery and design. You've got myself there as a nurse consultant in CAMHS. We have a public health consultant. We have a GP with CAMHS specialism. We have a consultant paediatrician and a consultant psychologist who all sit on that clinical reference group. And that reports directly into Barnardo's quality and clinical governance group, which is chaired by our Chief Operating Officer for Children's Services. And that provides that full strategic oversight for those safe and inclusive services that we continuously try to improve. It also ensures that we meet those contract standards for NHS, for example, the PCREF or the PSERV, which I'm sure many of you on here will know about, and that requirement of kind of our yearly quality account as well. And it makes sure we are proactive and that we're learning driven. And we have a clinical governance framework in place, which sets out the structure for quality and safety and accountability. And again, that's aligned to UK national standards, includes kind of leadership, clinical effectiveness, service user experience, etc. Next slide, please, Beth. I think it's really important that to point out that when we've done Bird, we've taken into account lots of the national standards, as well as our own internal community approach and what we call our framework for delivery, which is the CISO, which I'll come on to. So a couple of examples here: the suicide prevention in England, the 5-year cross strategy. That emphasises that integrated community-based intervention for children and young people, and it focuses on reducing suicidal rates and improving support for self-harm, which Bird links into. And also the NHS England MDT neighbourhood support. And we know that that looks at shifting towards community-led mental health offers. And that talks around NDT, so children and young people receiving that wraparound support from mental health practitioners, social workers and the voluntary sector staff, which again Bird feeds into, and that neighbourhood-based support as well, so embedding our mental health services locally rather than in hospitals. And that, I think, really importantly, is that cross-sector collaboration. So really strengthening those partnerships between our NHS colleagues, our voluntary sector, education providers, which Bird really aligns to. And I just want to touch on that we're aware of the new medium-term planning framework as well, and that emphasis within that on moving care away from hospitals and acute settings into community and neighbourhood. So for us, it's thinking about how can the voluntary sector influence and support that, and how can Bird be integral to those local plans that will be developed around establishing mental health in emergency departments and improving those emergency department performances. I think that paper talks about kind of reducing, making sure 85% of patients are seen within under 4 hours, and that there's a reduction of numbers waiting over 12 hours. So it's how does Bird support that going forwards? And then I touched on our CISO framework. So our CISO framework stands for, and I hope I'm going to get this right, child-directed, strengths-based, systems-focused and outcomes-informed. It's a whole service delivery framework, which is an evidence-informed structure for the delivery of our mental health services. It really provides Barnardo's with structured outcome-informed methodologies to shape our practice and to demonstrate kind of our service impact. And it includes training to staff as well to help shape that practice that we deliver. And it's implemented, or is currently being implemented into all our mental health services, so all our mental health contracts, as a standard quality approach across Barnardo's. Thank you. I think it's back to yourself, Kadra.
Thank you so much, Beth, Donna, and Emily, for that brilliant overview of Bird, why it was needed, and how it works. And Donna, I was just literally nodding my head because as you were speaking, all of you, I was like, this is just such a great example of that key shift in the 10-year plan from hospital to community, whilst also integrating the service within lots of the existing services and provision and places where children and families already are. So really taking that holistic and child-centered approach. It made me think of all of the ongoing conversations at the moment around the role of a trusted adult in terms of like prevention and early intervention in young people's mental health. But I think Bird also shows how important it is and how it can work in urgent and crisis pathways as well. So thank you for that. Just a gentle reminder for me in terms of any questions anyone has or any reflections, please feel free to put them in the chat and we'll come back to this later. So now we're going to move on to what we've been learning around Bird and its impact. So over to you, David.
Thank you, Kadra. Okay, hello everybody. I'm David Woodhead. I work at the Centre for Mental Health. I'm the Associate Director for Research, and I have been a researcher along with several others, some of whom are on this call today, researching, leading the evaluation of the Bird service. And I have to say, it's been a highlight of recent times to be able to work in this way with Barnardo's on this particular initiative. I want to start with an anecdote, and the anecdote is very fresh. Earlier this week, I was with Kadra. We were facilitating a workshop for colleagues in a mental health system that has growing need and growing inequality and significant reduction in resource. And we were showing a number of examples of the work we've done. And when we showed this, when we discussed bridging the gap, that our evaluation of Barnardo's Bird service, somebody actually said, Bird gives us some hope, gives us the hope that actually we can still do good stuff. Actually, we can do things that are cost effective, that have high impact and are well received by children and their families. And I think really that's the starting point, and that probably is the end point of the presentation I'm going to do, which is that I think there's real hope here to think about how we can do things differently and learn from this hard work that colleagues at Barnardo's have put into this project. Next slide, please. Just a little bit about Centre for Mental Health. We are an independent charity. We are fearless in our pursuit of addressing issues around mental health injustice. We generate knowledge, and we do research, and we support policy development, and we train systems in terms of being able to meet that broader objective. And we are fiercely independent, but we do work very much within the kind of service of mental health equity. Next slide, please. I just want to show you this. This is a picture of the report. It is on our website. I would encourage you all to read it if you've not read it already. You can see that I was but one researcher of many. This was very much this was a collective effort of a number of talented quantitative, qualitative, and economist researchers. And I would encourage you to read this, and indeed many of the other reports on our website, but particularly when you're thinking about BIRD. Next slide, please. And this is a copy of the infographic. Everything in the report is there, captured in essence on one side of A4. So I would encourage you to look at that. It's a very timely way of conveying the key aspects, and it's those key aspects that I'm going to describe now. Next slide, please. I don't need to tell you what BIRD is. You've just had the most brilliant introduction to it from Beth and Donna and Emily, so we can skip this slide. Talk to you a little bit about the research methods. So we were challenged with looking at the process, looking at the initial outcomes of the project. It was ours to understand, to help build knowledge, to understand how you move from this idea into practice, how you capture the learning when you're working with multiple partners and with families, and how to be able to get as full a picture and to understand, is this working? How does it work? And how could we replicate it? And as such, we had a mixed methods approach. We had quantitative outcomes and qualitative insights. We looked at various data sources, such as referral records, wellbeing scores. We did interviews with children, families, and practitioners. And there was economic analysis. There was return on investment, which was basically set up to show whether the money that was put in was well spent, and a social return on assessment, which actually suggests that for the money that you invest in such a programme, what is the economic impact across a much broader system? And indeed, we worked in it as a learning partnership. So this, I think, was why it was such a fulfilling experience for those of us that worked on it from the Centre for Mental Health side, was that we weren't just engaged to go in as evaluators to do a piece of evaluation and then to step out, but actually to really work alongside our colleagues, to meet frequently in workshops, to pool knowledge as it was being developed, and to really deepen our understanding, and to be as agile as we could to be able to make sure that the information that we were collecting was useful. Next slide, please. Our design principles, obviously, our principles were built around what makes BIRD different, holistic and Chard-led. It was important that our research approach reflected that we understood that the community-based notion of it, that we were understanding that in our evaluation we were able to reflect on the relational nature of care and also the trust that is needed for building partnerships, and that we really wanted to be as flexible as indeed BIRD was in its flexibility for meeting the needs of the people it was working with. Next slide, please. So thinking about BIRD, we obviously, as good evaluators, we started with a kind of understanding of the demographic reach. What we saw was that 50% of the people that the children and young families that BIRD engaged with were from highly deprived areas, that there was a broad age primarily from 8 to 18, that the service was inclusive of gender and neurodiverse identities, and the people that were engaged were ethnically diverse, although we do acknowledge, as indeed we very often do with such programmes, that more work needed to be done around cultural specificity and making sure that we're really getting to those communities that we know traditionally services are not open to. Next slide, please. So this is the slide. I think this is where the magic happens on this slide. This is the bit that I really want you to hold as you come away from my presentation, because this tells you what BIRD achieved, and I think this is quite significant. This is something really to hold on to. So 418 children were supported. 97% of them, just stop for a moment and think about that. 97% of them reported improved well-being. I mean, these scores are unusually, extraordinary. 99% of them felt well treated. 96% of them said that they felt listened to. So what we're talking about here is a program that was not only in its delivery was not only listening and tailored to the needs of the people to the young people that it was working with, but actually the outcomes that was generating are really very high. we did some calculations. We looked at what typically we would expect for a readmission rate to an emergency department in the first 6 months after an intervention for these families. And we predicted that that would probably be about 21%. We then looked at how many people represented to bird within 6 months, and that was 2.8%. So even with so using that as a kind of metric to understand what we're talking about is that those very high figures are not only beneficial in the moment, but seem to have some long-term impact on the well-being of children and indeed their families. And when we looked at costs, we looked at for every pound invested in this, what was that? How much did that relieve the system? And we thought that actually pretty much it broke even. So even though this was a really early pilot, the economic analysis suggests that it's a little bit cheaper, if you like, than actually it would cost if it was being delivered within traditional structures. But then when we looked at the economic social return, what this suggests is that for every pound spent, there's £3 of social return is actually accrued across the system. So what we've got here, the picture that's emerging, is a system, is a project, an intervention, a program of work that is not only good value for money, it's high impact, and it's very well received by people, by vulnerable people, the children that needed the support. Have the next slide, please. In addition to all that statistical data, we had we spoke to young people and their families, and indeed you will hear much more of this in a moment from Lisa. But people telling us things like he's smiling again, she's sleeping better when they're talking about their young people, that the young people valued being heard, and that parents told us that as a result of the intervention they could see improved mood and coping at school and a better kind of interaction with the day-to-day challenges of life. And that this overarching thing, and this comes back to the Barnardo's factor in this really, which is important that we hold on to, which is that support did not feel procedural, it felt personal. It was that relational aspect of really building relationships with the young people and the families that shone through in the qualitative data. Have the next slide, please. So again, similar, the ethnographic insights that we generated was that children described their support workers as kind and understanding and easy to talk to. They enjoyed the opportunity for the creative activities, to interact in informal spaces, not non-clinical spaces. And parents actually talked about a kind of renewed connection with their children as a result. And again, this overarching theme about the relationality of the work, not just a transactional kind of moment in a suite of interventions. The next slide, please. So why does bird matter? I'm coming to the end now. Bird matters because it addresses a critical gap in services for all the reasons that colleagues from Barnardo's just described, but our research supports that. That obviously these kids might not meet CAM's criteria, but it doesn't mean that they're not in some crisis, defined in a non-technical sense, if you like. That bird offers timely and relational support, and that prevents escalation. So it's good in the moment, but also it has positive knock-on effects. That bird works as part of a system, and it was very much that view that underpinned the ethos and made it so relevant to families' lives. And that the non-clinical, flexible nature of it, as well as this underpinning ethos of relationality, was absolutely critical, as well as good value for money with solid economic return. So it's not just that this is better, it's also that it's better value for money. Next slide, please. Implications for service change. So ICBs, we would say, should commission bird and other VCSE-led equivalents. There's something very much about the greater integration. This is something we talk about a lot at the centre. And there are other reports that I can point you to if you're interested in it about how to work in partnership with a much more a kind of determination with organisations from the VCSE sector, that it showed that we really do need kind of improved coordination across services, and that includes this explicit recognition of the value of non-clinical relational support because it's better. It has high quality impacts for the young people that were engaged, and that we need to design services that listen and adapt to the views of children and young people. It was this very strong nature of the engagement of young people which gave Bird its shape and its success. Next slide, please. Key messages: what does Bird teach us? Relational care works. It's not only effective and ethical, which we already knew, but it's also economically sound. The early support prevents further crisis. We can see that in our predictions and our estimations around representation, and also what families told us. We know that voice matters, and we really need to centre at the middle of our work the needs and the aspirations of young people, children, young people themselves. And actually, that generally, overall, we can do better. What Bird shows us from a strategic level is that greater trust between sectors at this moment in time in terms of delivering healthcare that's relevant and effective is absolutely crucial. Next slide, please. There you go. Any questions? Thank you very much.
Thank you, David. What fantastic results and really heartwarming findings all around from the evaluation. Really can't wait to see what we learn as this work is sustained and hopefully scaled up as well nationally. At Centre, we've been relentlessly campaigning recently for greater investment in children and young people's mental health as part of our Future Minds campaign. We often point to this stat that shows that it's 100 times cheaper to support young people in the community than in hospital. And I think Bird is just such a brilliant example of models and approaches we can take there. And yeah, you pointed not just to the economic benefits, but really clear mental health, social and system level benefits as well. So thank you and the team for all your brilliant work, and all to the young people and project leads who've contributed to the evaluation. So we're going to move on to any questions now. So if you have any, please feel free to drop them in the chat, or if you want to raise your hand as well, I'm happy to come to you. But I want to maybe start off with you, Lisa, because we haven't heard from you yet, if that's okay. I would love to kind of hear from you how you would describe in your own words the impact Bird has had on you and your family.
Thank you. Obviously, I'm the parent of Amelia. My daughter was under Barnardo's. She's just completely different. She's a happy child. She's doing so much better in school. Only last year, I think it was 76.61% attendance. This year, so far, touch wood, I hope she's not poorly, but she's had 100%. She's not had one day off. She's so much happier. She's not self-harming anymore. She's just doing so much. She's just different. She's back to Amelia. Got my Millie Moo back, as I called her. Oh. But that's thanks to Barnardo's. I just can't. It's an amazing charity. It really is. I was looking about the feedback. So this is actually the experience that she had, and she put that about how Amy really understood her, listened to me. Even though she was a stranger, it felt like she was my best friend. And it was like every time she came to the house, because it was during the 6 weeks holiday, so she'd come in the house, I'd sit in the dining room, so I'd leave them to it in the living room, and you could just hear them laughing and talking, and it was just such a lovely feeling that she was in a happy place. Amy really helped her. She changed the way that she now sees things. She helps her with controlling her anger and many other things. People deserve the help that I did with Amy. So Amelia knows that Barnardo's has helped her, and she said that people need Amy. And I was like, well, it's not just Amy, it's the whole of Barnardo's that can help the children. It's just amazing. It's a really good charity.
Oh, what a wonderful and powerful testimony there. Thank you so much for sharing that.
No, you're welcome.
Yeah, we all said we wouldn't get teary before in our catch-up, but yeah, just honestly incredible reflections there. Thank you so much for that.
You're welcome.
Did we have any questions? So yeah, we've got one, I think, from Sandra here, which is at the point of delivery where there may be a range of interventions applicable, who or what defines the intervention offered?
So she was actually took into A&E. She was not eating. She was in a very, very bad way. And we called for an ambulance because she just passed out. And then they rushed her into hospital. And then that's where they put her through to Barnardo's, because CAMS wasn't really for her. So then that's when we went down the different route of Barnardo's. But it was thanks to New Cross Hospital, as you were saying, that put her through to, because I'd never heard of Barnardo's. I just thought it was just a charity shop that sold clothes, and I always shop in there. I didn't actually understood what it was for. And like I was saying earlier, I think that needs to be more known to schools and everywhere for
Yeah.
children to reach out, and parents, because parents need help for the children.
No, absolutely. Yeah, thank you, Lisa. Emily, did you want to come in as well on that question?
Yeah, if I may, Kadra, thank you.
Yeah.
Just to say that when we receive a referral into service, we do have a panel discussion across the team. So we look at the most appropriate allocation in terms of who has capacity to work with a child or young person. And then once we've got all the assessment intervention, we do some cross-lateral checks as well. So we make sure that if we speak to the school when we've got consent from the family and from the child or young person. So we do those multilateral checks to ensure that we're not duplicating anything that may have been done previously or any other service that may be engaged with the child or young person. But then we do use a range, because of the model that Donna described, the CISO model. It's very child-led, it's very goals outcome focused. So we work closely with the child and with families where that's appropriate to set goals and set interventions based on what the child needs or what we understand from the referral and from the assessment process. And we have a range of sort of what people might know as more traditional modalities. So we use elements of cognitive behavioural therapy, of resilience building, of work around emotional regulation, strategies around anxiety, all of the sort of core components that we might think of in terms of supporting mental health and wellbeing. But it's really built into a child-focused, outcome-led plan, which is led by the child, guided by the child, and regularly reviewed and evaluated by the child. So I hope, Sandra, that answers that for you. It's really bespoke to each individual that we're working with and each individual family.
Yeah, brilliant. Sandra, I can see you've got your hand up, so very happy for you to come in as well.
Oh, thank you.
Thanks.
I just wanted to say, you mentioned the school. I'm not suggesting that it's applicable in the case just referred to, but so if the child is being excluded or is in inclusion rooms or and so on, which is going to be, you know, applicable in a number of cases, is that part of a package that is developed, or is it just, you know, this Barnardo's works with the person and does that, but it's divorced from what's happening from the school, that the negative stuff that's happening in the school? That's what I'm trying to get at.
If I can come back on that, is that okay, Kadra?
Yeah, of course, yeah.
Sandra, again, as I say, it really depends on what the outcomes are identified at the during the intervention, at start of intervention. So if school-based issues, whether that be around support internally at the school refusal, attendance issues, anything to do with educational achievement, we work again both with the child and young person, with the family, but with the wider school system. So we attend a lot of sort of multi-agency meetings. We work closely with school pastoral leads. We've often used school as sort of a longer term step down strategy as well. So we do lots of work with the school to think about what the individual needs might be. So it may be born out of anxiety, it may be born out of mood, it may, you know, trauma that the young person has experienced previously. So we work really closely with the school to have that wraparound support for the child and young person. So it's all very individual depending on what the child's needs are. But one of our aims and ambitions is that we work with the community around the child, which of course school is paramount in that, or education provision is paramount in that, to ensure that we've got that holistic approach.
Thank you.
Thank you. Thanks, Sandra, for the question. Okay, maybe I'll move us on to another question for Barnardo's colleagues, if that's okay. I really wanted to hear from yourselves, what was something unexpected that you learned throughout the evaluation process?
Shall I go, Beth, Emily? That'd be okay. So I think coming from an NHS and clinical background, like Beth said, kind of 30 years over with my blue lanyard rather than my green one. And I'm going to say I've been guilty of this myself. I think what surprised me the most was the misconception and the preconceived ideas that our statutory colleagues have about the voluntary sector. So, you know, not really fully understanding what the voluntary sector can bring. Concerns that risk isn't managed appropriately, worries that our staff aren't trained or qualified appropriately, questions around the quality, you know, quality isn't the same in the voluntary sector. And now I'm speaking from that experience, really, by leaving the NHS and coming over to Barnardo's just shy of 3 years ago. It really isn't true. And I think so although I've been part of that, I think it surprised me that that still is there. You know, our policies and procedures, our standards we have in place here are incredibly robust, and we're required, and as I've said, we're mandated to align to kind of contract standards for the NHS. So I think the learning for me and the surprise for me was it's that kind of preconceived ideas is so embedded, and how do we work with that? How do we work with that? And I must say there's preconceived ideas from the voluntary sector towards the NHS as well. So it's how do we work with that? How do we reduce that and eventually eliminate it to really get that true cross-sector working?
Yeah, no, great point and reflection there. Like, there's real need for a cultural shift, isn't it? And for children and families, they don't distinguish between the voluntary sector and NHS, you know, they want support. And hopefully there's a good opportunity now with the 10-year workforce plan for the government to really think about like the untapped potential of the voluntary and community sector and how we can, just work in a more cohesive way. But yeah, Beth, did you want to come in on that question as well?
Yeah, and it's similar actually, in building on what Donna said there. There's a phrase that gets battered around, you've probably heard it before. It's there's more pilots in the NHS or in the healthcare than in the RAF. And before joining Barnardo's, I used to work in the innovation space in mental health, and I can vouch for that. At times it feels like there's pilots and evaluation and pilots and evaluations for evaluation's sake, but this one has really stood out to me, and it's felt like a privilege to work on the bird service and with the bird service with other colleagues. And as David said at the start, I can see why others would say that this actually provides some hope that the system can work together to make a difference. And that's not saying it's all sunshine and rainbows. You know, there are reflections and learnings in that report that we really need to take on and take forward in anything else we do. Multi and across different system working is complex. You know, we're coming from different organisations. What I think has been really unique about Bird is that it's had this shared common vision from the start, that what we ultimately want to do is utilise this fantastic gift of this money to improve outcomes for children and young people, and then take that gift and expand it and grow on that. And thanks to our corporate partners, that's something we're able to do. We're able to continue with the service, but we're really excited to see how we can continue to do that elsewhere as well. So it's not just another pilot, it's not just another evaluation, it's really meaningful and long-lasting support for children, young people and their families.
Yeah, brilliant. Thank you so much. We've got another question here, and Donna, I know you touched on the patient and carer race equality framework, so that might be a bit relevant to this question. But we had a question from Catherine. How have you tailored interventions for diverse communities, those with perhaps limited English, and how do we embed more culturally sensitive approaches? Wondered if you had any thoughts on that.
Yeah, I'll come to Emily to kind of answer the tailored interventions bit, because obviously Emily's the operational side of this. But I think I alluded to the PCREF. So we've had our PCREF framework in place since March last year. I can share the link on the chat in a bit. So we produced our report, we produced our action plan, and we're just in the process of updating our Q2 report for people. And I think that's enabled us as an organisation, as a charity, to look at what do we get right at the moment and where do we need to improve. And what we've ensured is that it's not a standalone document. We've linked it into our EDI work. We've linked it into a new piece of work that we're doing around reviewing all our children's services of delivery. So it's not a standalone. And I think, there's a lot of work that we do around kind of how we bring in interpreters. There's a lot around that we're doing for our language. So even our report is published in the top 5 languages, across our nations. So, but I think, I'll put the link in so people can dig deeper and have a look, because I could take up the rest of the time talking about the PCREF because I lead on it. But there's lots of kind of training that we do internally in Barnardo's that looks at that cultural competency. There's lots of feedback that we're obtaining. And a quick example before I move to Emily would be, we're aware that our experience of service questionnaires that we use in mental health services do not have any ability for our families and our young people to report on around race. So we are working with CORC, which is the Child Outcome Research Consortium. We're members of that. We're working with them. I've got a meeting with them this afternoon to look at what are other kind of areas doing of this. Is there something that we're missing here, or do we need to develop our own? And if we develop our own, how ethical is that? So that we can really start to understand further as a charity what our what our communities need, really. But I'll come to Emily for that tailored interventions bit.
Thank you.
Yeah, I think the important thing is to reflect back to the CISO model that we talked about. So what we do is very child-led, but we're not adverse to exploring and having conversations around anything to do with trauma or impact that diversity and uniqueness of the child may have or may have caused or contributed to where the child or young person is at that point in time. So it's about exploring some of the uniqueness of the individuals, whether that is around gender, race, disability, neurodiversity, and having those conversations. And as Donna said, all of our staff receive a big portfolio of training around the sort of areas of cultural competency and enable us to then bespoke our intervention plans, a bit as I answered with Sandra, so that they are very child-led, they're very child-focused. So we do work around lots of issues to do with sexuality. We work around some of the comorbidities with neurodiversity. We work both from a whole family perspective, but also with community partners and others in schools and communities, volunteering community sector, to ensure that we've got that overarching sort of awareness when we work with every child and young person and family.
That's fantastic. Yeah, I regularly point to the Barnardo's PCREF page to people as well. So yeah, fantastic work there. Thank you. Beth, did you want to come in on that point as well?
I did, yeah, and it's something that I think we don't shout about enough at Barnardo's, but it's the role of our volunteers, particularly how they've been utilised in the Black Country, where we know it's a very diverse community, and sometimes our workforce hasn't always been able to reflect that in terms of the matchmaking with the cases, and how we've been able to utilise volunteers to really, to use the phrase in here, bridge some of those gaps, support with translation, tailor the different interventions, build that trust when we're going on the different visits. I think that's so important. And I've worked with the team in the Black Country to start to showcase this a little bit more, because it's a real secret sauce, I think, to the success of the bird programme. And I have actually a wonderful case study document that if anyone is interested in understanding a little bit more through that lens, I'd be more than happy to share. Of course, they're all anonymous for reasons we'll all understand, but it's just showing the power of volunteers, something that I think Barnardo's as an organisation does not shout about enough, and I think it's part of the success of this service.
Yeah, no, absolutely. Thank you, Beth. Lisa, I wanted to come back to you. Maybe if you don't mind sharing your thoughts on what's one thing you would take away from being, engaged with the bird service.
Oh gosh, put me on the spot now. It's just, don't know, what would I take? I did put it on Facebook, social media. Sorry, I shouldn't have said that. I did put it on social media that I did highly recommend the service of Barnardo's if any of my friends or family is struggling with the children, to go to Barnardo's. It's just trustworthy. Felt safe with the company. So thank you again for the charity.
Oh, that's lovely. Thank you, Lisa. Carolyn, you've got a question. You've got your hand up.
Hi everyone, I'm Carolyn Green. I'm the Chief Nurse from Black Country Healthcare, and I lead the CAMS services and also take oversight of the system group. So thank you for the presentation, and thank you to Lisa for sharing her experience and story. I think I just wanted to say a few things and kind of challenge colleagues on the call just to start to think differently. So it isn't about CAMS does this does this. It's actually about how you come together. How do you come together and work out who's the best fit, because there's more children and young people out there and such a massive amount of demand. So we have to work out what options are. And I think the beauty of our service with Black Country, it's about the acute trust, the mental health trust, the third sector coming together and wrapping around people who need us and working what fits for a person, being person-centred. So this isn't about replacing CAMHS, this is about complementing a whole pathway approach. And this is about making sure that we do it well, but not over medicalising injury, psychological upset and distress. So I think it's a really exciting opportunity for us to see if we can do this in other areas, to see if we can gain the evidence base. But actually, let's look at alternatives to accident and emergency and not build rooms and areas. Let's build pathways and services that choose community first. So thank you everyone for all your brilliant work. We are very grateful to work with you, and we will continue to, I hope, find new ways to continue.
Yeah, oh, thank you so much, Carolyn. What a really brilliant intervention there. And yeah, completely, we are with you. Emily, you wanted to come back to that point as well?
Yeah, I should come back to that point, because we do work really closely with our Black Country colleagues, and I think that my Barnardo's colleagues in St Helens would say similar. And I think that's one of the real strengths of the model. It's about complementing existing structures and existing systems. And one of the reasons that we initially went to the Black Country is that we had got some established relationships, and we were aware we worked really closely with the CAMHS Commissioner, who I know is on the call as well, and with other colleagues from CAMHS Crisis and across the system, and that inroads into the community and acute trust, so both the primary care trust and the community trust, to really understand the needs of the local area and really understand what some of the pinch points and the challenges might be, but also being able to have that really strengthened relationship with the existing structures. And we've got a really brilliant relationship with our CAMHS Crisis colleagues in the Black Country, and have really navigated a lovely partnership and a lovely pathway between the two services and the two organisations. So it's been a definite benefit of the approach.
Yeah, no, absolutely. We've touched lots on the relational aspect of the intervention itself for families, but there's a relational element across systems as well, isn't there? So yeah, absolutely. So David, can I come to you? Because I know you're also involved in some of the evaluation of the neighbourhood 24/7 pilots. And so I just wondered, based on your work in that space, but also this evaluation, what's one sort of key thing you would urge decision makers to consider?
One thing, I think I really do think it's this issue about thinking differently about a child presents with this kind of problem that we choose to interpret in this kind of way, and therefore we prescribe this kind of clinical intervention. I think obviously there is a role for clinical interventions, of course there are, but I think we could do a lot more in terms, especially thinking about this shift from treatment to prevention, about how do we hold children and young people and their families before they get to such a point where they in a system that is much more difficult to navigate. And and I think there's something about working for the benefit of families. I think the thing that I really want everybody to know about this is that not only were there benefits clearly for the children and young people and their families, but economically this stacks up in a really sound way as well. And I think I've been doing this for a while, and often you either have one thing or the other, but to have both of those elements working in tandem, I think that's the one thing I would say about this.
Brilliant. We might have time for one more question if anyone's got any. Sandra, yeah.
Sorry, it's me again. You can tell I'm really excited by this.
We welcome your enthusiasm. Thank you. Go for it.
How did you capture the input from the families, say at the beginning and as the process went on?
Yeah, David.
How did you include their view? Was it? Hopefully, it's a co-produced thing. That's where I'm coming from. But how did you capture their views?
Well, there was a co-produced element in terms of the actual development of the initiative, which colleagues from Barnardo's can talk about more fully than I can. But in terms of an evaluation perspective, we drew on several things. So there were the questionnaires, the wellbeing questionnaires and the satisfaction questionnaires that people filled in. So that gave us a kind of bedrock of quantitative data. And then colleagues did interviews with children and families and practitioners, sometimes together, sometimes separate, to really kind of put some meaning, put some flesh on those bones that we captured in the numbers from the questionnaires. That was our bit of providing that bit of the interaction. But in terms of the actual development, Emily, you've got your hand up.
Yeah, just to come back again, the whole from the point of referral where we make initial contact with the families, and hopefully Lisa's experience can reflect some of this. We do a really thorough assessment process, so we co-produce the service that we're going to deliver alongside children, young people and their families. So it's very goal orientated, child led. Families where it's appropriate, we bring families into discussions and then we talk about, and I know that Emma and colleagues in the chat have put something about into, you know, measuring outcomes and measuring the impact of interventions on specific outcomes for children, young people and families. So we work very much to a goal-based outcome framework where we regularly review how's it working, what's going well, what's not going so well, and then we modify and change the approaches as we move on. But as I think what Lisa was referring to was some of the evaluation process as well. So we use that in terms of building and changing the service, and it has changed slightly over time. It's got some fluidity to it. So we did talk about the number of sessions that we work with a child, young person, and building flexibility into that so that we aren't just one size fits all in terms of the service offer. We try and make it as bespoke to the needs of children, young people. So we hope that children, young people and families have been co-producing the service as part of this whole pilot phase since day dot, really.
Yeah, brilliant. I was in a meeting yesterday and somebody put it so brilliantly about measuring to improve, not just to prove. So I think that captures what you said there a little bit. Beth, do you want to come in with some quick thoughts as well on that?
Yeah, just a couple. So you'll see, I think it's page 19 of the report, that children, young people are actually the cohort that we heard from most, at least in those qualitative interviews. So above parents and carers even, but above bird service colleagues and above health professionals across the system, they were our biggest cohort that we wanted to listen to. And then I think that's reflected in the qualitative data as well, that 96% of children and young people feel that their views were taken seriously, and the same 96% felt that they were really listened to, quite often for the first time. And that for me is more than any economic stat and anything else. If they feel heard and they feel that those opinions are taken seriously throughout the whole process with Bird, that's more important to me than anything else.
Yeah, fabulous. Okay, so I'll start to wrap us up because we've got 2 minutes left to go. Thank you, everybody, especially our speakers, for all your thoughtful and inspiring contributions today. Thank you, Lisa, for joining us and for sharing your journey and reflections as well. A big thank you to everyone who also joined us. We really appreciate you taking some time to be a part of this important conversation today. Before we wrap up, just a quick few notes from me. If you'd like to make a donation to Centre for Mental Health to support our ongoing work, you'll find a link to this in the chat. We do also accept Banksy paintings. How amazing was that as well? If anyone's generous enough to lend us one.
It's been shredded, Kadra. It's been shredded.
And you can sign up to our newsletter as well. I think Hannah will share a link to that to keep updated with our latest research, our events and our campaigns. And finally, we would really value your feedback. So you will also receive a feedback form to tell us how we can make these events even better and useful for you all. But yeah, just thank you for joining us, and to our partners at Barnardo's as well for collaborating with us on today's session. I hope you all found it useful, and hopefully we can kind of continue these conversations in this space. But for now, take care, and wishing you all a great afternoon. Thank you.
Bye-bye.
Thank you.
Thank you, everybody.
Bye.
Goodbye.
Thank you.